Hello, I'm Jeremiah and I'll be talking about pre-hospital pain management. In this presentation, I'll be presenting information from two papers. The first is Pain Management in the Pre-Hospital Setting, published in 2005 by the Journal of Special Operations Medicine. This is essentially a republishing of another paper, which I'm also using, titled Pre-Hospital Pain Management, published in 2003 by the National Association of EMS Physicians. I found this quote pretty relevant to the presentation, and it was on one of the papers I used to create this presentation. Care more for the individual patient than for the special features of the disease. What I think this means is that we should treat the patient and not how we believe the patient should be presenting. If the patient says they feel pain, we should consider this a valid complaint even if their vital signs are within normal limits. We have to remember that pain is a subjective finding and that your pain is not their pain, and vice versa. Let's start out with the history of pain management. The literature on the right side is from a paper called Pain Management in the Pre-Hospital Environment. Even during the Civil War, people that were transporting the injured tried to treat pain. They administered alcohol and used splinting to ease the pain and suffering associated with gunshot wounds, broken bones, and other traumatic injuries. Unfortunately, as time went on, medical care continued to evolve, but EMS was left behind. During its infancy, EMS was used more to transport the dead and less as a means of medical treatment. More recently, within the last 30 years, EMS has progressed, and more focus has been on treating patients as well as treating pain in the field. Myths and misconceptions about pain in our patients. We as a whole are pretty poor at pain management. We give excuses like, I don't want to skew the doctor's exam. I don't want my patients calling 911 just for pain meds. My patient didn't look like he was in pain. And then we also have our unconscious bias, which can prevent treatment of pain and other medical complaints due to the way our patients look, act, and how many times we run on them. We have to remember that the patients we run on a regular basis will one day actually be sick or hurt. The rest of this presentation will be from the position paper by National Association of EMS Physicians. I just wanted to point out that this paper was written 15 years ago, which at the pace that medicine changes, wasn't written that long ago. The National Association of EMS Physicians believes that the relief of pain and suffering of patients must be a priority for every emergency medical service system. The association has found the adequate pain control is not provided for several reasons. The most common reason is underestimation of the patient's needs, and even after asking the patient what their pain is, those providing care judge that the pain is less than reported. What they have found is that the most reliable indicator for the existence of pain is the patient's self-reporting, and that self-reporting is something we need to take seriously. The organization has recognized 5 points to help assist systems in treating pain. The first, protocols need to be in place for pre-hospital pain management. The second, pain assessment tools. The third, pharmacological and non-pharmacological pain management. And the fourth, documentation. And the fifth is medical oversight with QA/QI oversight in place. Protocols should include mandatory assessment of both the presence of and severity of pain, use of reliable tools for assessment of pain, indications and contraindications for pre-hospital pain management, non-pharmacological interventions, pharmacological interventions, mandatory patient monitoring and documentation of patients before and after analgesic administration, transferal of relevant patient care and information to receiving healthcare facilities, quality improvement, and close medical oversight to ensure appropriate use of pre-hospital pain management. Three pain assessment tools can be used to measure pain and how effective your treatment is. These listed are by far not the only assessment tools that are available, but just 3 that I have listed. The visual analog scale is a scale where the far left is equal to 0, or no pain, and the far right is 10, or maximal pain. The patient chooses a point on the scale appropriate for their pain level. The numerical rating scale is where the patients report their pain from a scale of 0 to 10. The verbal rating scale is based on 5 pain levels indicated in large print on a sheet given to the patient. no pain, mild pain, moderate pain, severe pain, and unbearable pain. Have the patient choose the option that best corresponds to their pain. I think an important part of treating our patients is talking with our patients and explaining why they are hurting. This can ease anxiety and cause distraction from stimulus that is causing them pain. Immobilization of fractures and application of cold packs can reduce spasms and inflammation. I think as a BLS provider, I was much better at this than an ILS provider because I didn't have the option for pharmacological interventions. As an ALS provider, we need to remember that sometimes the smallest things can provide the most relief. Opiate medications used in conjunction with NSAIDs can provide short-term and long-term pain relief. In systems where patients often end up in triage where they will wait long periods of time, fentanyl can be used for the ride to the hospital, and Toradol can be given at the same time. By the time you get to the hospital, the Toradol is kicked in, providing lasting pain control while they wait to be triaged and seen by a physician. Documentation is important not only to show what you did for the patient, but to provide information to the QI/QA department. QI/QA is important. That way there's oversight not only for the efficiency of pain management, but what can be changed to improve pain management in the future. Thank you for listening, and I hope this was informative. Have a good day. My references: pain management in the pre-hospital environment and pre-hospital pain management.